Bismillah Rahman Rahim. My name is Dr. Fawad Farooq, and I am uh, an interventional cardiologist. And today we're going to discuss a very common clinical scenario we see in our daily routine practice. And this is on the slide. You can see a 42 years female with palpitation, vertigo, that is slight feeling of the surroundings to be moving around, or headache, few hours, and having a blood pressure of 190 by 90. What to do? And this patient is landed in your clinic or in a situation where you're dealing emergencies. So these are few symptoms and slightly high blood pressure. Very important what to do. And whenever I discuss such situation in my own clinical meetings, I found different set of answers and see practically how the general practitioners are managing such kind of patients. They immediately give captopril, sublingual, sometimes captopril and injection furosemide. So there are various ways of addressing such problem. So let's discuss how to approach such kind of situation when you have a patient with increased blood pressure to a certain limit, which is usually more than 180 systolic and more than 120 diastolic, which is, you can say, is a hypertensive crisis kind of thing. So what I would suggest, that always confirm diagnosis, that you are really dealing with a hypertensive urgency or emergency. And that we'll discuss in a moment. What's the difference between urgency and emergency? Second, always try to evaluate what's the etiology behind this sudden increase in blood pressure. Is it non-compliance status? Is it any secondary cause which has led to this controlled BP going into uncontrolled state? Or any secondary reasons like drugs or any other thing? Similarly, always try to look for complications in your patient, whether your patient is having any complications of ongoing target organ damage, because they are very important. And always assess your patient. Is he having other comorbids along with high blood pressure in the background or not? Is he or she diabetic? Is or she dyslipidemic, ischemic heart disease, or any other thing which governs her cardiovascular risk? So an patient with increased blood pressure, confirm diagnosis, try to evaluate etiology, look for complications, and assess for other comorbids. And these things, these four things, should be assessed in a way that it should be assessed with history, with clinical examination, with preliminary investigations like ECG, urine DR, urea creatinine. These things will help you in assessing or fulfilling these four objectives. Then, after assessment, you are in a position to decide whether your patient with increased blood pressure is having hypertensive emergency, urgency, or pseudo emergency. Today, I'm not going to tell you about the treatment of these three conditions. What I'm going to tell you today is that what you have to look for to decide about emergency, urgency, and pseudo emergency. Now, first I'll exclude pseudo emergency. This is a condition which I personally, you very rarely found it as a terminology in scientific books or in data. It is actually a condition where you have reactionary increase in blood pressure due to some emotional stress, pain for other reasons, or anything. And whenever you take care of those additional things, your patients come back to normal state. This is pseudo emergency. So that pseudo emergency observation should be done once you exclude emergency. And emergency is if a high blood pressure patient is having ongoing target organ damages. Now, what do you mean by ongoing target organ damage? We know that blood pressure involves these major organs like brain, heart, kidney, vascular system. So if your patient, along with high blood pressure, having any evidence of TIA or stroke, he's having hypertensive emergency. If he's having ongoing ischemia or MI or pulmonary edema or heart failure state with high blood pressure, again, this is hypertensive emergency. He's having proteinuria with RBCs in the kidneys, acute glomerulonephritis going on with high blood pressure, again, hypertensive emergency. Or evidence of aortic dissection. So any patient who's having, so that means with high blood pressure, what you have to do, you have to judge for these things. Whether your patient is having any hint towards involvement of these target organs, their clinical symptoms, their signs, their evidences from the investigation, ECG, X-ray, echocardiogram, or anything. Similarly, clinical examination, any focal neurological deficit, any craps in the chest, patient is tachypnic, desaturating. So these are all things you have to do. I'm not going into I'm just giving you the approach towards a patient who's coming with very high blood pressure. Now, when you see all these things and you found any of the evidence of target organ damage, your patient will be in the category of hypertensive emergency. If he's having high blood pressure but no evidences of target organ damage, he is either urgency or pseudo emergency. And that you can differentiate by just observing few minutes, 15 to 30 minutes in your clinic. If your patient's pressure drops down to normal or slightly raised, then mean you're dealing pseudo emergency. And if it remains raised above 170, 180 systolic or 110, 120 diastolic without target organ damage, then this is hypertensive urgency. And in this situation, the hypertensive emergency is only the condition where you have to admit the patient. In urgency, you can send your patient with proper workup on multiple oral antihypertensive. In pseudo emergency, you have to look for cause and monitoring of blood pressure to see whether your patient is really baseline hypertensive or not, and certainly the appropriate workup investigations for other comorbid ECG or other things. So I hope this brief description or discussion about a patient who's coming with high blood pressure will give you an idea how to approach pseudo emergency, emergency, and urgency. Let's see what happened with our patient. So he was having no comorbids and no ongoing symptoms. And after observation, 20 to 30 minutes, keeping her in a relaxed environment, BP reduced to 138. And it will very commonly happen with your patients. If you judge them in a way that you just observe them and see them after 15, 20 minutes, but that you can do once you see that your patient is having no evidence of target organ damage. That's very important to judge in your patients, that your patient shouldn't be having any target organ damage. Thank you very much for the listening and hope this will help you in assessing the patients with high blood pressure.